there was a discussion in which it was mentioned that the young microbiologist or young clinicians may not have no clue about leprosy. And I hope that Dr. Malathi, who has extensive experience on clinical examination of leprosy patients, would set that right. And Dr. Malathi is additional professor and head the Department of Dermatology and Venerology and Leprosy at JIPMER. And she's both MD and DNB. She's enrolled for ICMR Young Medical PhD program in 2025, received 5 extramural grants, published 90 articles in national and international journals, presented 50 papers in national and international conferences, and has authored 8 chapters in textbook and co-authored 16 chapters in textbooks. So Dr. Malathi would now explain about the clinical diagnosis and management of leprosy. Dr. Malathi, please, you would project your own slides. So please upload the slides and go ahead.
Thank you, sir. Thank you for that introduction. And a very good evening, all. I would like to thank the organizers for giving me this opportunity to share my knowledge on or whatever I've learned over the past years about the diagnosis and management of leprosy, being a dermatologist, because now it is primarily a dermatologist arena where the clinical diagnosis of leprosy is based on the cutaneous manifestations. So before I go to the clinical diagnosis, just the basics. So why it is important for us is India, Brazil, and Indonesia contribute to more than 80% of the new leprosy cases worldwide. And so our current strategy is towards zero leprosy. So it's high time that we know about the early clinical diagnosis, because in the previous presentation, sir was insisting on zero transmission, zero stigma, zero disability. Everything relates to picking up the disease early, treating it, so that we cure the disease, we prevent the disability. And once all this is prevented, there's no stigma and discrimination associated with leprosy. So we all know Mycobacterium leprae. I won't go into the details. We need to know that why skin is primarily affected, because the skin lesions tend to develop in the cooler areas of the body. And this Mycobacterium leprae grows best at 27 to 30 degrees Celsius. And also it has an affinity for Schwann cells. And that is why it has both cutaneous and neural involvement. And so far, it has always been only Mycobacterium leprae, but we have another species, that is the Mycobacterium lepromatosis, which has been described in 2008. However, the clinical aspects are poorly categorized, and it has been associated with the diffuse type of lepromatous leprosy. However, other types like borderline lepromatous and necrotic types of ENL or the Lucio leprosy have been commonly associated with Mycobacterium lepromatosis. And now genetic testings are being done to identify the species of leprosy, whether it is Mycobacterium leprae or Mycobacterium lepromatosis. So the source of infection is a multibacillary case where there is so much of basilemia. This is a very long incubation period of 3 to 5 years, and the portal of exit is via the nose and then followed by an ulcerated skin, and there can be transmission via intact skin in multibacillary cases. The most common route of spread is household contacts because of overcrowding, lack of ventilation, poverty, and poor housing. The attack rates among household contacts, within 5 years, there is a transmission attack rate of 5 to 12%. And this is happens because the Mycobacterium leprae can remain viable in the dried nasal secretion for at least 9 days and in the moist soil for at least 4 to 6 days. That is why overcrowding and lack of ventilation predisposes to the transmission of leprosy among household contacts, especially among the multibacillary cases. So now moving on to the clinical spectrum. So once a person is exposed to Mycobacterium leprae, that is following an incubation period of 2 to 5 years, not all develop the disease. 95% of the patients do not develop disease. And in that 5% develop indeterminate leprosy. By indeterminate leprosy, what we mean is the leprosy can be self-limited. That is, it can be cured spontaneously, or it may progress to develop a full-form clinical disease. We need to understand that leprosy is a disease primarily which manifests based on the immune response the individual is going to mount against the bacilli. Not all who are infected with Mycobacterium leprae will produce the same kind of manifestation. Based on one's immunity, the leprosy can be spontaneously cured, or in some it can be a limited disease. In those whose their immune response is not able to mount an appropriate immunity against the bacilli, then it becomes a whole body basilemia resulting in the multibacillary spectrum. So among the 5% who develop indeterminate leprosy, which usually presents as a single ill-defined hypopigmented skin lesion, which is most often not noticed, 75% of the cases undergo spontaneous healing, and only 25% develop clinical disease. And among the 25% who develop clinical disease, there can be a spectrum. Starting from the tuberculoid pole, where it's a contained disease, we have the tuberculoid leprosy, we have the borderline tuberculoid, and then gradually as we progress down where the immune system is not able to mount a response, we have the borderline leprosy, borderline lepromatous leprosy, and the lepromatous leprosy. And based on the immune response, we do have complications like type 1 reaction, which occurs in the borderline spectrum. That is the borderline tuberculoid, borderline lepromatous, and borderline lepromatous leprosy. And we have the type 2 reaction, which occurs predominantly in the lepromatous pole, the lepromatous leprosy and the borderline lepromatous leprosy. I'll come to it later. So this is an overview of how leprosy manifests. Now, when do we suspect leprosy? We mean that the cardinal features of leprosy. There are 3 cardinal features. Number 1 is definite loss of sensation in a hypopigment or reddish skin patch. We can have a lot of conditions which present with hyperpigmented skin lesions. For example, vitiligo. For example, common fungal infection like tinea versicolor. But they are not associated with loss of sensation. We can have areas of skin with loss of sensation. For example, in people with neuropathy. In such cases, we can have only areas of loss of sensation, but they will not have a hypopigmented area of skin. So presence of a hypopigmented area of skin associated with the loss of sensation can occur only in leprosy, and hence it is a cardinal feature. Why they have included reddish skin is, as mentioned, reaction is an immune response. So the skin becomes, the leprous patch becomes erythematous and reddish. So that is why reddish skin has also been included in the cardinal feature of leprosy. Next, coming to thickened or enlarged peripheral nerve with loss of sensation or weakness of the muscle supplied by that nerve. We can have thickened or enlarged nerve in conditions like such manual laborers. They will have thickened or enlarged nerves, or conditions like amyloidosis, neurofibromatosis can all have thickened nerves, but they will not be associated with loss of sensation or weakness of the muscle. Post-trauma, there can be weakness, but they will not have a thickened nerve. There can be loss of sensation in peripheral neuropathy, but again, they are not associated with thickened nerve. So when we have a thickened or an enlarged nerve and is associated with loss of sensation or weakness of the muscles, then we have to think of leprosy. And third one is a laboratory criteria where presence of acid-fast bacilli in a slit skin smear. We just take a scraping from the slit skin smear and we do AFB staining and we find positive acid-fast bacilli in the smear, then that also happens only in leprosy. So presence of at least one of the 3 indicates that the patient is having leprosy. So these cardinal features are very important, and the first and the second cardinal feature shows that leprosy is predominantly a clinical diagnosis, which can be diagnosed at the field level. So the common classification of leprosy across the clinical spectrum is the Ridley and Joplin classification, where I already discussed that we have the tuberculoid leprosy in one extreme, and we have the lepromatous leprosy in the other extreme, and in between we have the borderline spectrum. So what do we understand by a patient from growing from TT to LL is that as you go down the spectrum, the immunity of the patient reduces. The immunity to mount a response against Mycobacterium leprae reduces. So as the immunity decreases, there's whole body basilemia. So the number of skin lesions tend to increases. And also the number of bacilli also increases. So when the number of bacilli increases, the slit skin test is also positive across the spectrum. And so as the number of lesions increases, there'll be a symmetric whole body distribution of lesions in the lepromatous spectrum, whereas we'll have limited lesions in the tuberculoid spectrum. And the morphology of the lesion, it can just present with macule. Macule means just an area of hypopigmentation. A plaque is a raised lesion, a papule or a nodular lesion, or there can be just diffuse infiltration of skin. So in leprosy, any of this morphology is possible. And in addition, we have the Indian classification. We have the indeterminate leprosy and the pure neuritic leprosy. Of late, we do encounter a lot of pure neuritic leprosy where we do not have skin lesions, but the patients present with neuritic features with deformities. So we need to have a high index of suspicion of patients who present to us with sudden onset claw hand or foot drop. We need to consider the possibility of Hansen's. So now moving on to the clinical features. When do we suspect indeterminate Hansen's? So I told it is a very vague, ill-defined hypopigmented macule. So when a patient presents like this, there are so many reasons that we will consider. As a dermatologist, we'll think of pityriasis alba, we'll think of tinea versicolor. Any of these could be a possibility. So I told the most important thing is about checking for sensation loss. But again, the indeterminate Hansen usually presents on the face or on the buttock. So in which of these patients we need to identify this is in household contacts. We have a case of leprosy whom we have diagnosed recently. could be a paucibacillary or multibacillary leprosy. We need to screen the family members. So when we screen the family members and we come across this kind of lesions, then have a high index of suspicion. The lesions that occur on the buttock and all, there'll be loss of sensation. But a lesion occurring on the face has multiple neural innervations. So loss of sensations may not always be present. So in a household contact, presence of these vague, ill-defined hyperpigmented macules on the face or on the covered areas, especially on the buttock, and in children, think of the possibility of indeterminate Hansen's. And then coming to the next spectrum, that is the tuberculoid Hansen. We have this classical description of the saucer right way up. It's just like a saucer that is right way up. So how does this present? It presents as a very, very well-defined margin with the margins that are infiltrated and the center is depressed. So when we see a very well-defined patch with infiltrated borders, then we know it is a TT Hansen. Why this happens is the body's immune system is so good that it tries to contain the bacilli localized to that particular area. And that is why we have this well-defined lesion. Usually the number of patches will be 1 to 3. And because of the body's immune system mounting a response, it will destroy all the cutaneous nerves here. So there'll be complete loss of sensation. And because of destruction of the nerves, there'll be loss of sweating. So the patch will be completely dry. This is how it will present. A very well-defined lesion with the infiltrated margins and completely dry surface with total loss of sensation. So that we have to suspect tuberculoid Hansen. So this is how it presents, a very well-defined macule. So that was a raised lesion. It can also be a flat lesion. Still, we see that the margin is elevated. Now we move on to the borderline tuberculoid Hansen. So in borderline tuberculoid Hansen, slowly the body's immune response is not able to contain the infection. So what happens? It starts to spread. So we describe it as a broken saucer. That is, we have a saucer here and one side of the saucer is broken. These are what we call as the satellite lesions. So the lesions are well-defined in one side but ill-defined in one side, and they have these scattered lesions like this. What does it indicate? Multiple new lesions are trying to form, and all these lesions will coalesce to form a large lesion. So that is the borderline tuberculoid Hansen. Again, here also there'll be loss of sensation. In fact, there'll be decreased sensation. In a tuberculoid Hansen, there'll be complete loss of sensation. Whereas in a borderline tuberculoid Hansen, we'll have decreased sensation. Again, the surface will be dry. In comparison to the tuberculoid Hansen, here the margins are well to ill-defined with satellite patches. So you can present in any of these lesions. This is a well-defined patch, and here we have one more satellite patch that is developing, and the patient is also having a claw hand. So these are how, in all ways, how a borderline tuberculoid Hansen will present with the ill-defined margin, and it starts extending. These are all the manifestations of a borderline tuberculoid Hansen. See, here multiple hyperpigmented lesions have started to occur. They'll all coalesce to form large lesions. Sometimes we can even find patches which are seen in the palms of the hand. These are all atypical presentation. We need to have a very, very high index of suspicion to identify a patch like this. Now moving on to the borderline Hansen. So a borderline Hansen is a spectrum in between the tuberculoid and the lepromatous spectrum. So it will have features of both a tuberculoid as well as a lepromatous leprosy. So what we mean by this is we call it as the punched out appearance or the Swiss cheese appearance. If we take this particular region, the center is depressed and the margin is elevated. This is like a saucer right way up. So this describes a tuberculoid spectrum. Whereas the outer side, if we see, it's like a saucer that is inverted, where the margins are sloping outwards. So this is a characteristic feature of a borderline lepromatous leprosy. So when we have these kind of annular lesion, where there is a punched out lesion, where the center, the margin is elevated, and on the periphery, the margins are sloping out, these are indicators of borderline Hansen. So this is also, we have the annular lesion. The importance of this borderline Hansen is based on the immune response of the patient, or the moment we start the patient on MDT, they can upgrade to a better spectrum, that they can become tuberculoid. Or if the immunity is worsening and the patient is not taking treatment, it can downgrade to a borderline lepromatous leprosy. So these are all the presentation of the typical annular morphology. If you can clearly make out, the patient is having typical annular morphology. So that is a borderline Hansen. And it's a very, very transient period, because your patient will usually upgrade to the borderline tuberculoid or downgrade to the borderline lepromatous spectrum. So borderline lepromatous, already I told, it will have an inverted saucer appearance, which means that the center will be infiltrated and will having a sloping margin. And it will be, because of the infiltration, it will be very succulent. In contrast to the tuberculoid leprosy, where I told it will be all dry and scaly, here it will all be shiny and succulent. And We saw there the tuberculoid spectrum, it was all few lesions. In the tuberculoid, we have 1 to 3 patches. In the borderline tuberculoid, maybe around 3 to 20 patches we may have. In the borderline, we may have up to 20 to 50 patches. But here, when it comes to the borderline lepromatous, there'll be multiple patches and they are tending towards symmetry. All over the body it is involved and they're tending towards symmetry. And here we'll still be able to count the number of patches. That is borderline lepromatous leprosy. That is the inverted saucer appearance. So multiple hyperpigmented lesions. They can be infiltrated or they can be just hyperpigmented macules. So they can just present like these vague hyperpigmented lesions or just scaly lesions like this. And now moving on to lepromatous leprosy. There I told it is tending towards symmetry. Here it will be bilaterally symmetrical lesions. And lepromatous leprosy can present as only hypopigmented lesions, or it can present as coppery red macules, that is the hypopigmented lesions, bilaterally symmetrical, or it can present with these kind of large nodular lesion. If you can make out, the skin here is totally infiltrated and from the infiltration there are nodular lesions, or there can be multiple small papular lesions. Again, the underlying skin will be infiltrated. So when we find bilaterally symmetrical extensive lesions, which could be hypopigmented, just pigmentation, or it could be nodules, or it could be papules on an infiltrated skin, think of lepromatous leprosy. See, multiple papules all over the body like this. We have to think of lepromatous leprosy. Diffuse bilaterally symmetrical lesion, infiltrated skin. And when the infiltration is so much, what we have is a leonine facies. So the skin is thrown into folds. It is really unfortunate that even after we have considered that leprosy was eliminated in 2005, going with the saying which Sir started off with, it was statistical elimination and not really a biological cure, we still see patients who come with this kind of lepromatous leprosy. This patient presented to us last year. So over so many years, and for the first time he presented to us, there were so many people who missed this kind of a manifestation that this patient has been having leprosy. And he was also not aware that he had leprosy. And similarly, this patient presented to us 2 years back. And he had this infiltration post-treatment. What we have, the sagging earlobe is known as the Buddha ears. So these are all how Hansen's patients can manifest. If you see, even his lips are infiltrated, his ears are infiltrated, his entire face is thrown into folds. That is known as leonine facies. This is how leonine facies presents. And this is a 16-year-old boy who presented with Hansen's, and he presented to us a year back with completely infiltrated earlobes and ulcerated ENS. He presented with Lucio type of leprosy, which I'll come to it later, were completely necrotic lesions with which he presented with us. And he's a child who presented with lepromatous leprosy. And because of the diffuse infiltration, they can have loss of eyebrows. That is known as madarosis. So, and we also see this kind of infiltration on the earlobe. So all these signs we need to look into when a patient presents to us with hyperpigmented or hyperanesthetic lesions or presents with nodular lesions. And earlobe infiltration is a very, very classical signs of leprosy, especially lepromatous leprosy. In the early cases, you have to stand behind the patient. You stand from behind the patient and see it from the sides, then these earlobe infiltration will be seen better, will be appreciated better. And the earliest feature of a lepromatous leprosy is dependent edema and ichthyosis. Why this happens is, and apart from epistaxis, why this happens is because the nerves are affected, the nerves supplying the blood vessels are also affected. So the vasa vasorum gets affected, and because of that, there is loss of vascular tone resulting in dependent edema. And because of destruction of the autonomic nervous system, they will have complete loss of sweating. And when there is no sweating, there becomes dryness. So presence of extensive xerosis or dryness of skin with this kind of extensive ichthyosis, we have to think of Hansen's as one of the possibility. Then because of this infiltration by the leprosy bacilli, we do have something known as the banana finger. So we have such stubby and infiltrated broad fingers with presence of hyperpigmented lesions or multiple nodules. Think of Hansen's. And there is another variant of lepromatous leprosy that is known as the histoid Hansen. So in lepromatous leprosy also we saw nodules, but in histoid Hansen, there are nodules, but there I told they arise on an infiltrated skin, but here they appear on a normal skin. So when we find these kind of asymptomatic nodular lesions that are occurring on a normal looking skin, and patient comes from an endemic area, think of the possibility of histoid Hansen. And it's important to identify histoid Hansen or think of its possibility because the moment we diagnose histoid Hansen, we need to give MDT for 2 years. Normally, MDT is given for 1 year, but histoid Hansen has to receive treatment for 2 years. 2 years. So 24 months of MDT is essential for hystoid Hansen. So the difference is nodular lesions arising on a normal looking skin. They need not always be nodule. They can also be like these kind of plaque lesions, but the underlying skin looks normal. So think of possibility of hystoid Hansen. So this is about the cutaneous examination. To summarize, as we go down the spectrum, the number of lesions keep increasing and the sensations from the tuberculoid Hansen, because of complete destruction of all the nerves, it will be complete loss of sensation. But as we go down the spectrum in lepromatous leprosy, it will be only a decreased sensation. It won't be a complete loss of sensation. And the morphology of the lesion, an indeterminate Hansen is ill-defined hyperpigmented macule, whereas a tuberculoid is a saucer right way up. And we have a borderline lepromatous that is saucer inverted, and borderline is a punched out lesion, and lepromatous leprosy diffuse infiltration followed by multiple papular lesion, and hystoid Hansen's, which occurs as nodular lesions on a normal looking skin and or associated with loss of sensation. And then we move on to the nerve examination. So that is the second cardinal feature. So nerve examination, we need to first check for thickened nerves. So it is the peripheral cutaneous nerves. The closer the nerves to the body, the core body temperature is high, but leprosy always prefers a cooler body temperature. So the more outer, the more peripheral nerves are commonly involved. So we can have the supraorbital and the supratrochlear nerves that are involved. When we come down to the nerve, the greater auricular nerve, if you ask the patient to turn one side and make the sternocleidomastoid prominent, we'll see this greater auricular nerve running over the sternocleidomastoid. Then we have the radial nerve, usually is not involved in leprosy because it is higher up and deep within. But when it comes out as a radial cutaneous nerve just above the styloid process, there it is superficial and it can be palpated there. Then we have the median nerve. Median nerve is below the flexor retinaculum. It is not always possible to palpate a median nerve, but still we can palpate it if we try to make the palmaris tendon prominent, and medial to it we'll have the median nerve. And ulnar nerve is the classical nerve that is involved. Why? Because it is behind the olecranon process, and every time we keep moving our limb, there is micro trauma that is happening to the nerve, and it is the most peripheral nerve. So leprosy bacilli commonly prefers the ulnar nerve involvement. So the commonly involved nerve in leprosy will be ulnar nerve, followed by a radial cutaneous nerve and the median nerve. When we come down to the lower limbs, we have the common peroneal nerve, which is winding around the shin of tibia. And the shin of tibia, it is again superficial. That's a common area that will be involved. And we have the posterior tibial nerve and the sural nerve. So I'll just quickly show how to palpate for the nerves. So ulnar nerve, we know that just flex the elbow and we have to palpate behind the olecranon process, and there we'll find the nerve and we have to trace the nerve up. And if the nerve is traceable upwards, it means that it is thickened, and it is always in comparison to the opposite limb. And median nerve, you have to flex the wrist a little. The palmaris tendon will become more prominent. So medial to the palmaris tendon, whatever we feel is the median nerve. And above the styloid process, what we feel is the radial cutaneous nerve. It is a very, very superficial nerve and easily palpable. To palpate the common peroneal nerve, we have to put a thumb in front of the tibial tuberosity and run the other fingers behind. And once we just try to palpate, and whatever is snapping between the other fingers here, there'll be around the neck of fibula, there'll be something that is snapping, and that will be the common peroneal nerve. For the posterior tibial and sural nerve, we have between the Achilles tendon and the medial malleolus. Whatever we palpate medially will be the posterior tibial nerve. The same thing between the Achilles tendon and lateral malleolus, what we palpate is the sural nerve, or we can also palpate the sural nerve between the two gastrocnemius heads. But usually the common site is medial side is posterior tibial and lateral side is sural nerve. And we can also palpate the supraorbital and supratrochlear nerves. So these nerves will be thickened and enlarged. They can be asymmetrical or they can be symmetrical. And then we move on to the sensory examination. Just nerve involvement alone, nerve enlargement alone doesn't tell it is Hansen. It has to be associated with sensory loss or motor weakness. So these are all the common points where we have to check for sensation and protective sensation along the distribution of ulnar nerve, these 3 points, for median nerve, these 2 points, and for radial nerve, this point. And similarly for the lower limbs, for posterior tibial nerve and the deep peroneal nerves. In these areas, we have to check with ballpoint sensation. It is somewhere between a deep pressure and pain. We can just check with the ballpoint for these sensation. Even for an extensive evaluation, we have to check using the Semmelweis monofilament testing. But what we need to understand is there are 3 sensations that we need to check: hot and cold, pressure, and pain. So the first sensation to be lost in leprosy is hot and cold sensation. And even in that, the cold sensation is the first one to be lost before the loss of hot sensation. So in a field level, what we do is we generally check with the ballpoint pen. So there, why we do that is if your patient has loss of pain sensation, that is the last sensation to go. If a patient has loss of pain sensation, it means the other two sensations have already been lost. So that is the principle we do that. So if the patient, when we check a ballpoint and if the patient is able to feel it, then go for fine touch using a wisp of cotton. Even that your patient is able to feel, then what we do is we do go for hot and cold sensation over the patches. And if the patient is not able to perceive hot and cold sensation, then again, that is considered as Hansen's. So never say there is no loss of sensation by just checking with a ballpoint pen. Always ensure that we also check with hot and cold sensation, and loss of hot and cold sensation is the earliest loss of sensation in Hansen's. And facial nerves can also be affected in leprosy. The common facial nerve to be affected are the fifth and the seventh nerve. So we call that can be tested using the corneal reflex. So here the sensation is by the trigeminal nerve, the corneal sensation. So by a wisp of cotton, when we try to touch the cornea, when the sensation are perceived, the immediate reflex is for the eyelids to close. The efferent, the muscular action is by the facial nerve. So that is the seventh nerve. So when the fifth nerve is paralyzed, when we touch with the wisp of cotton, there is no impulse, and so the facial nerve will not close. And this is a very, very important testing, because if there is loss of sensation and there is no protective reflex, the patients are prone for exposure keratitis, and exposure keratitis results in blindness, and that is completely a preventable cause of blindness in a patient with Hansen's disease. Same thing, if there is facial nerve palsy and the patient's eye is not able to close and the cornea gets exposed, then that also results in blindness. So it's very, very important to check for corneal sensation. Now moving on to the motor examination. So the common nerves that we check for are the ulnar nerve, the commonest nerve that gets affected, the median nerve. The radial nerve is usually not affected in leprosy. And what happens in the radial styloid process, the radial cutaneous nerve. So there is no muscular involvement. So it's only the cutaneous sensation that is lost, and there is no muscle involvement. In the lower limb, we check for the common peroneal and posterior tibial nerve. And for the facial nerve, we check for the orbicularis oculi, that is the lag. For presence of lag of thalmus will be the deformity, and we need to check for the corneal reflex. So for ulnar nerve, we check for these muscles, the abductor digiti minimi. The patient will not be able to abduct their little finger. And then we check for the lumbricals, the medial two lumbricals, and both the palmar and dorsal interossei are being supplied by the ulnar nerve. So they'll also be completely paralyzed. So the palmar interossei is for adduction, and the dorsal interossei is for abduction of the fingers. And then adductor pollicis, that is on the thenar eminence. So all these are supplied by the ulnar nerve, and deformity of the ulnar nerve results in ulnar claw hand. In median nerve, the medial two lumbricals are supplied by the median nerve, and abductor pollicis brevis is supplied by the median nerve, and opponens pollicis, the opposition is possible only by median nerve. So when lumbricals go, we get the median claw hand, and when the opponens goes, we get the eighth thumb deformity. And for the lower limb, the common peroneal supplies the full extensors of the foot, and the extensor hallucis longus. So the patient will present with foot drop. And posterior tibial supplies the soles, the intrinsic muscles of foot. So once they are gone, the patient will present with claw toe. So I'll just show the test. So this card test is to check for the palmar interossei. You just have to ask the patient to hold a card between the fingers. And this is not the right way to do. The patient has to hold the card the same way that the examiner is also holding. So the same interossei that you are checking, the patient's interossei should also be the same. And the same hand should also be tested. And we have to see how much the patient is able to hold that card. If there is weakness, the patient won't be able to hold the card, and you will be able to pull it out. And this Igawa's test is to test for the dorsal interossei. The dorsal interossei, both the dorsal interossei will attach to this middle finger. Hence, just lateral movement of the middle finger alone will tell that whether your dorsal interossei is intact or not. Then we have the book test. This test for the adductor pollicis. So we ask the patient to adduct with the thumb. And when there is weakness, the ulnar nerve is gone, the patient will not able to adduct. Instead, he will try to flex the thumb. The flexor pollicis is supplied by the median nerve. So the median nerve takes over. So we know that there is ulnar weakness. And this is the pen test for median nerve, where we keep a pen and the patient has to move the thumb at right angles and touch the pen. And if he's not able to do that, he'll have the eighth thumb deformity. Now, how do we grade the voluntary muscle testing at the field level? We just need to know whether it is strong or normal, able to perform movement exactly like how the examiner is able to do, or when he's able to give resistance. Weak is when they're able to perform but not against resistance, or when it is paralyzed. So we call this as SWP scoring. And so in a field level, we don't have time to do all the testing. So a simple test to see the upper limb is do a beak test. So the moment your patient does this, it shows that your radial nerve is intact. That is, he's able to extend the wrist. And then by doing this, this is known as the lumbrical position. This is how the lumbricals work. So the lumbricals are working and he's able to oppose the thumb. So the median nerve is working. So just ask the patient to do this beak test. And if the patient is able to do that, it means that the muscles are intact and the nerves are also fine. For the lower limbs, how do we check? For the posterior tibial nerve, we ask the patient to stand on the toes or spread the toes because it supplies the intrinsic muscles of the soles. And for the common peroneal nerve, we ask the patient to walk on the heels. So just by doing these simple tests at the field level, we know that whether the nerves and the muscles are intact or not. And then the third cardinal feature is to do a slit skin smear, and where we go for the acid-fast bacilli, and there is the Ridley logarithmic scoring from 1 plus to 6 plus. Now moving on to the complications of Hansen's. So the first one is the type 1 lepra reaction. So this type 1 lepra reaction happens in the borderline spectrum. That is, it happens in borderline tuberculoid leprosy, borderline leprosy, and borderline lepromatous leprosy. It is a type 4 hypersensitivity reaction. So for example, a Hansen's patient, a tuberculoid patient or a borderline tuberculoid patient, we start them on multi-drug therapy. The body is able to mount an effective response with the help of the drugs that we are giving. So the natural response is with an increased immunity, there is granuloma formation, and because of that, these already existing patch will become erythematous and edematous, and there can be complete destruction of nerves. And that is when a patient will present with erythematous patch, edematous patch, and it will be very, very tender, and sometimes because of nerve destruction can even present with facial nerve palsy. Similarly, a patient with Hansen's who had only a patch, and then after starting MDT, suddenly the patient's immunity improves and he develops destruction of the nerves because of the granuloma formation and can present with sudden onset neuritis and Clauhan. So these are known as type 1 lepra reaction. See, a facial patch, and the moment the patient develops a reaction, he has involvement of the facial nerve resulting in lag of thymus. The plaque is erythematous and edematous. Such erythematous and edematous plaque will happen. So this is type 1 reaction. Type 2 lepra reaction happens whenever the bacillary load is high, which usually occurs in the borderline lepromatous and lepromatous leprosy. So in the BL and LL spectrum, we have type 2 lepra reaction, which is a type 3 hypersensitivity reaction. A type 3 hypersensitivity reaction is an antigen-antibody complex. So we have plenty of lepra bacilli. The body is not able to mount a cell-mediated immunity, and that is why there's so much of bacilli. So what does the body do? It tries to produce antibody. The other immune system gets stimulated. It's not cell-mediated, it's not working. So let us stimulate the antibody-mediated immunity. But an antibody-mediated immunity does not work against leprosy bacilli. So what happens? These antibodies become useless. So these antigen and antibody combine together with complement recruitment form these kind of nodules known as erythema nodosum leprosum. They are red, they are nodules, and happens in leprosy. Hence the term erythema nodosum leprosum. They will occur in crops and they are transient lesions. So that is how we differentiate it from the nodules of lepromatous leprosy. Nodules of lepromatous leprosy are persistent, whereas a lepra reaction, it will be erythematous and it will last for 3 to 4 days and then it will spontaneously resolve. And then again, patient will have fever and they'll have crops of these lesions. So these lesions can also ulcerate. So they are known as ulcerative ENLs. The severe form, the patients can present with such ulcerated lesions. Many a time patient will present to us in reaction. When the leprosy lesions are there, they will be asymptomatic. They'll not present to us. But the moment they have fever and these kind of ulcerated nodules, that is when they will present to us. Then we have to think of the possibility of erythema nodosum leprosum. See, these are all the atypical presentations which we had recently. This patient presented with a pustular lesion. We thought it could be a normal bacterial infection, folliculitis or furuncle. But the moment we saw the face of the patient, he had facial infiltration and all. So we suspected, and he had madarosis, probably Hansen's. And we did a slit skin smear from this that came positive, which means that that was a nodular ENL. And usually we have papillonecrotic tuberculate, a hypersensitive lesion of TB that presents as these kind of necrotic lesion on the glans penis. But here, her patient with Hansen presented with ENL, necrotic ENL involving the glans penis. This is also an atypical manifestation. And this is Lucio phenomenon. Leprosy bacilli is angioinvasive, which means that when there's diffuse infiltration of leprosy, these bacilli can go block the blood vessels. When they go block the blood vessel, there'll be cutaneous necrosis. And this is a type of leprosy known as the Lucio phenomenon, where the patient will present with necrotic lesions. And unless we suspect leprosy and immediately start them on MDT and steroids, we are going to lose the patient. Some 6 months back, we had a patient in ICU with these kind of extensive ulcerated lesions, and the diagnosis was not sure. And when we had to go and see a reference, we identified that this is a part of necrotic ENL because the patient, the Lucio phenomenon, because the patient had earlobe infiltration. So the earlobe infiltration gave us the clue. We immediately got a slit skin smear and we started the patient on steroid and MDT, but we lost the patient because the diagnosis was delayed, because patient directly presented to the medicine ICU, and Hansen's was not suspected in this case. And he was being treated as a case of necrotic lesions because of some other bacterial infection. Now moving on to other complications like anesthetic complications. So loss of sensation, and when there is loss of sensation, they're more predisposed to develop trauma. And because of trauma, they'll develop blisters, and those blisters can result in trophic ulcers. And because there is loss of sweating, the skin becomes dry and they'll have fissures. So whenever we have deep fissures, a patient, normally when we have fissure foot, we all immediately present to the doctor because it is painful. But these patients, because of loss of sensation, the fissures will be very deep and bleeding fissures, and still they are not bothered about it. So think of the possibility of some neuropathic involvement. So common neuropathic involvement, only two things. One, it could be diabetes or it could be Hansen's. When we have such deep trophic ulcers, and if the patient is not diabetic, always consider the possibility of Hansen's. Like this, they can present with trophic ulcers. Then paralytic complications, we can have ulnar claw hand, we can have ulnar and median claw hand, and this claw hand can be a complete claw hand, or it can be a flexible claw hand or mobile claw hand, or it can be a flexed claw hand. So claw hand auto amputation of fingers can happen. So these are all how a patient, especially pure neuritic Hansen, where we don't have the patches and the patients can present to us only with these kind of deformities. There are trophic ulcers are there. So we need to think of Hansen's. Lower limbs, they can have foot drop. This is foot drop. And they can have these kind of trophic ulcers and swollen fingers. So the banana fingers, you have to think of Hansen's. Eye, exposure, the lag of thalmus, there is the upper eyelid is not closing properly. And because of that, the cornea is exposed, loss of sensation. So exposure keratitis with lag of thalmus. These are also complications of Hansen's and preventable cause of blindness. That is something that we need to understand. So once we identify these patients, we treat them. We have given MDT and all that. We have cured them of the leprosy. But what about the stigmata? The deformities stay with them for life. And this is what results in discrimination. So this is what we need to prevent. How do we prevent it? By diagnosing it early and starting treatment early. So this is the WHO disability grading for hands and feet. When the patient doesn't have any deformity or any anesthesia, we call it as grade 0. We have only anesthesia but no visible deformity, it is grade 1. Presence of any visible deformity, even in the form of trophic ulcer or paralytic deformity, it becomes grade 2. And we need to avoid this grade 2 deformities. And eyes, 0, no eye problem due to leprosy. Grade 1, the patient is having vision of 6/6 or better, but the moment patient has corneal anesthesia, lag of thalmus, or severe visual impairment, then it becomes grade 2. Now moving on to therapy of leprosy. So what is the principle of multi-drug therapy that started in 1982? If we see this, normally a lepromatous leprosy patient who has full-blown bacilli, the number of bacilli on average is 10 to the power of 9. If we see rifampicin resistance is 1 in 10 power 7. Dapsone resistance is 1 in 10 power 6. And clofazimine resistance is 1 in 10 power 6. So what is the chance that a patient can have resistance to rifampicin and dapsone? 1 in 10 power 13. Rifampicin and clofazimine, 1 in 10 power 13. Dapsone and clofazimine, 1 in 10 power 12. And resistance to all three, 1 in 10 power 19. But the total number of bacilli in a full-blown lepromatous leprosy itself is only 10 power 9. So what is the possibility of having a resistance to all three drugs put together? 1 in 10 power 19. So it is impossible. So that is the principle of multi-drug therapy. So in 2017, there has been a recent classification of paucibacillary and multibacillary because the treatment of leprosy depends on this particular classification. So this is the recent classification which we are also following. So in paucibacillary, the number of skin lesions is 1 to 5, no nerve involvement, and slit skin smear is negative. In multibacillary, more than 5 patches, nerve involvement is multibacillary and slit skin smear positive. So, any case, irrespective of the number of patches or the nerve involvement. If slit skin smear is positive, it becomes a multibacillary. If your slit skin smear is negative, look for the number of patches and nerves. If the number of patches is more than 5, it becomes multibacillary. Even if the number of patches is less, but even if one nerve is involved, if just ulnar nerve is involved, it becomes multibacillary. The earlier classification had one nerve involvement as paucibacillary and more than one nerve as multibacillary. But now the classification has changed here, where just one nerve involvement also comes under multibacillary. That is the change in 2017. One nerve involvement also goes under multibacillary. So the treatment, earlier we had the blister pack with paucibacillary and multibacillary regimens based on 2 drugs for paucibacillary for 6 months and 3 drugs for multibacillary for 12 months. But now the WHO suggested uniform MDT, that is the 3-drug regimen with only change in the duration since 2018. And in India, we have started to follow this regimen, uniform MDT, from April 2025 onwards. So the regimen is with 3 drugs, rifampicin 600 mg once a month, clofazimine 300 mg once a month and 50 mg daily, and dapsone 100 mg daily. So all 3 drugs, irrespective of whether it is paucibacillary or multibacillary, only the duration changes. For paucibacillary, it is 6 months. For multibacillary, it is 12 months. And accordingly, for children, the dose changes. And one changes, if we diagnose it as hystoid Hansen, then we have to give multi-drug therapy for 24 months. There's something known as accompanied MDT, especially during the COVID scenario and all that, where it is supervised dose. This rifampicin and all that, we call it as a supervised dose, and every month patient has to come to us to get the drug. Whereas in such pandemic or there are some problems, in such cases, we can go for accompanied MDT, where we give the patient's caretaker at least 3 blister packs at a time, and they have to come 3 months later to receive the next MDT. So to ensure loss of follow-up or default. And during follow-up of the patients, very, very important for us to see that the compliance is proper and the patient has to complete this. Yes, there is a possibility of default. So, but the 6 months therapy for a paucibacillary has to be completed by 9 months, and 12 months of multibacillary should be completed by, 18 months. So, for example, a patient who has taken paucibacillary therapy for less than 3 months and then comes to you after a gap of 2 months, you have to always restart it. And similarly, a multibacillary who has taken less than 6 months therapy, and when they come back, you should not continue the therapy, but you have to restart from the beginning. We need to understand that any point in time, the patient has to have taken at least 2/3 of the dose that they should have been taken. That is what we mean by 6 months and 9 months and 12 months and 18 months. And during follow-ups, check if your patient has reactions, whether the patches are red, whether the patches are tender, patient has any nerve tenderness, any signs of weakness. And once we start MDT, the patient should start showing response. But despite MDT, if the number of patches are increasing, then we need to consider the possibility of resistance and also observe for side effects of MDT. The moment we complete this 6 months of therapy for paucibacillary and 12 months of therapy for multibacillary, we call this as release from treatment. This is a term that we use as RFT, release from treatment. And the whole focus is about prevention and treatment of deformities. During every visit, we are supposed to advise the patient. And there are certain special situations. For example, patients cannot take dapsone. They have side effects to dapsone. They have anemia. They have dapsone hypersensitivity syndrome. In such cases, in the old blister pack, it was only 2-drug therapy. So we had to add clofazimine. But now currently, it is all 3 drugs for both paucibacillary and multibacillary. We can just continue the MDT with rifampicin and clofazimine without giving dapsone. Because dapsone resistance is common, and even if dapsone resistance is there, we still continue it with rifampicin and clofazimine. There is no alteration that is required. But patients who cannot take rifampicin because of some side effects of rifampicin, or the patient has resistance to rifampicin, in such case, we continue with clofazimine and then we add 2 drugs, Oflox, minocycline or clarithromycin. Out of these 3, we add any 2 drugs for 6 months, followed by clofazimine with any 1 drug of these 3. So clofazimine is fixed. We are not able to give rifampicin. We will not give dapsone. Instead, we'll add Oflox, minocycline or clarithromycin. And here the treatment is for 24 months. So the moment patient has rifampicin resistance or not able to take rifampicin, we have to go for 24 months of therapy, because rifampicin is the only bactericidal drug in case of leprosy.
Dr. Malathi, can we leave it at this now?
Yes, sir. So can I just quickly go through after this? Nothing much, sir. I'll just
okay.
Yes, sir. If Oflox is not available, we can go for moxifloxacin. If clofazimine patient is not able to take, we take this ROM regimen, rifampicin, Oflox and minocycline regimen. And for drug resistance, already I told the regimen. These are all the newer anti-leprosy drugs which are being tried. And for lepra reaction, if it is mild, we treat with NSAIDs. If it is severe, we go ahead with steroids. Type 2 lepra reaction, we mild with NSAIDs, or we can also give thalidomide. And if it is severe, we go for steroids and other immunosuppressants. And as discussed earlier, chemoprophylaxis has been implemented. So for all those patients who are exposed and do not have leprosy, we have to screen the family members. And if the family members have leprosy, treat them. If they don't have leprosy, give them this single dose rifampicin. Immunoprophylaxis, ma'am will be discussing about it. And we have to give supportive therapy in the form of splinting. And we have a lot of dynamic and static splints. Surgical treatment, and sir already discussed that reconstructive surgery, 12,000 rupees is being given for these patients. And there are a lot of surgical rehabilitation which we can give for these patients. And this is very, very important, how we tell the patient to prevent the disability and rehabilitation. They have to daily examine the eyes, protect the eyes, patch the eyes to prevent exposure keratitis. They have to examine the hands for any wound. They have to apply oil, moisturize it, cover the wound, avoid exposure to harsh objects, care of feet, safe distance walking, and they have to use protective footwear. Or when they have trophic ulcer, we have to use a cast to offload. And this is the footwear that these patients wear, MCR footwear, which distributes equal pressure to prevent trophic ulcers. Physiotherapy, very, very important, passive and active exercises. And we can give all these kind of supportive aids for the patient so that they are able to handle their daily activities. So I would like to conclude by telling that whenever a patient presents with pale or reddish patches on the skin with loss of sensations, numbness, painful or tender nerves, nodules, or painless wounds or burns on the hand, or weakness of the muscles, think of leprosy. So early recognition is the first step towards cure and prevention of disability. Early diagnosis prevents not only deformity, but also discrimination, and eliminating leprosy begins with recognizing its early sign. Thank you.
Thank you very much, Dr. Malathi. It was extensive, and I hope and the clinicians will benefit by the details that you have mentioned and will be able to early diagnosis is what is required, and that will be